about 28 years old who met me with an acute episode of back pain. Upon dwelling his history, he said that every 6 months once or 3 months once he will get acute back pain, which makes him almost like bedridden. He has to take rest, he has to take medicines, and then over a period of time it gets better. But again, it used to come back with a vengeance. So this is one of the episodes that he has been having for the past 6 years or so. He's just 28 years old, but already he's having 6 years of back pain. And this time he want to make things clear that why he's having the back pain in spite of he going to gym and doing regular strength training and weightlifting. He want to know why he's having low back pain. His job is more of a sitting job. About 7 to 8 hours he used to sit, but he'll be traveling almost like 2 hours every day. Rest of the time he tries to be as active as possible and tries to go to gym. He's going to gym for almost 5 to 6 years. He's very strong. He lift very heavy weights and almost like 90 to 100 kg of weight lifting he does in the form of weighted squats and deadlifts. I'm going to read this MRI for you and make you understand the intricacies of low back pain and how to read an MRI. As a physio, what are the findings which are relevant? That is going to be the reason for the back pain. What you are seeing is T2 weighted image of the sagittal view. What you are seeing is the lumbar vertebra. This is L5, L4, L3, L2, L1. And the disc between L4 and L5 is degenerated. And the disc between L5 and S1 is also mildly degenerated. The other discs are pretty normal. A healthy disc is the disc which appears whitish in the T2 weighted image. Whereas a dark color like this in the disc indicates that the disc is undergoing degeneration. The degenerated disc is going to be the unhealthy disc, which is more susceptible for disc bulges and disc herniations. And you could see in this image, the patient is having L4, L5 disc bulge posteriorly and L5S1 disc bulge posteriorly. And you could see a small amount of whitish appearance over here. So that is a nuclear part. And what you see here is the spinal cord and then ending as the cauda equina. And these the cauda equina are the nerves which are going down and then it goes to the lower limb and the pelvic area. The white color appearance, what you see is the cerebrospinal fluid, which is very important for nourishing the nerve. This one is the ALL, anterior longitudinal ligament, and this is the one which is the PLL, posterior longitudinal ligament. As the disc is bulging here, it rips off the PLL, which is attached to the adjoining vertebra. So the posterior vertebral margin is lined by the PLL, which will get usually affected by the disc bulge. What you see is the mid-sagittal section. As I scroll down, you can see the foramen here. So this is the foramen through which the nerve will exit out. This is the left lateral foramen. And as I go up, this is the right lateral foramen. So this foramen is otherwise called the intervertebral foramen, which is the space between two vertebral bodies, which makes a space for the nerves to exit out. So what you are seeing here is the intervertebral foramen. And what you see inside the intervertebral foramen is the exiting nerve. Let's say this is L3 nerve. And this L3 nerve will exit from L3 and L4 vertebral bodies. So if this is L3 nerve, this will become L2 nerve, L1 nerve, L4 nerve, and L5 nerve. Sometimes the bulging disc will go backwards as well as upwards, which we call it as a superior migration, and that will go and disturb the nerve over here. That will be causing a classical radicular sign. Let me go to the T1 weighted image. In T1 weighted image, the water will appear dark. That's why the CSF, which was appearing white, is appearing dark in this image. And the nucleus pulposus, which is supposed to be white in T2 weighted image, is appearing dark here. But the bone is pretty brighter compared to the muscles. But the fat is always bright in T1 weighted image. This T1 weighted image is usually representative of the anatomy. So if you want to know the precise anatomy of the bones, this is the best image. You see the classic square shaped vertebral body. What you see as the black line is the vertebral end plate, which has no hydrogen proton. So it is hypointense, which is appearing pitch dark in the T1 weighted image of the MRI. So this is the intervertebral disc. In case of modic changes, you find some changes in the vertebral body over here. In this patient, the modic changes are not found to be there. You could see the alignment is better. The lordotic curve is maintained. What you are seeing is the ALL, and what you are seeing in the backside is the PLL is not very much visible here, unlike in T2 weighted image. And here is the intervertebral foramen over here. And apart from the nerves, you also have some blood vessels here, arteries and veins, and some amount of fat would be there. That's why this area is appearing white, because white indicates fat, because fat will be white in T1 weighted image. Like how you have subcutaneous fat here, like that, there's a fat here which shows a bright signal in T1 weighted image. Now let me go to the axial view. What you are seeing is the transverse section. This is anterior, this is posterior. Let me go through the anatomy of the axial spine. So what you are seeing is the lumbar vertebra. This is the lumbar vertebra. This is vertebral bony cut. So you don't see any disc over here. And this is the spinal canal. And what you see as the dot, dot, dot is the nerve in the spinal canal. And what you see here is the spinous process, and this is the lamina of the left and lamina of the right. And here is the superior articular facet, forms facet joint at the left side and facet joint at the right side. So in the MRI, this is left and this is the right. And that's how the orientation of the MRI is. And here is the cerebrospinal fluid, and this is a space for the nerves to go out from the spinal canal, and it takes its journey through the intervertebral foramen and it goes out and form lumbosacral plexus. In normal instances, the nucleus pulposus should be contained within the annulus fibrosus, but as with age, the phenomena tend to get changed. The nucleus pulposus will lose its water and then it becomes completely black. So if you see any patient after 40 or 45, you will not generally see the nucleus pulposus white in all the lumbar segments, and mostly in L4, L5, and L5S1 is the common segment where the degeneration used to happen, because L4, L5, and L5S1 are the most weight-bearing structures in the entire spinal column. That is the reason why most of the disc bulges are happening in L4, L5, or L5S1. What you see as a V-shaped ligament, this ligament is ligamentum flavum. So sometimes the ligamentum flavum will get hypertrophied and it becomes large, and that will go and compress the nerves over here. So this is one of the manifestation of spinal canal stenosis. Sometimes this facet joint will become arthritic and it becomes larger, and that large bone growth over the facet joint can also compress the exiting nerve. That is one of the reasons for foraminal canal stenosis. This is the inferior vena cava, this is the aorta, and this is psoas major. Here is the quadratus lumborum. Here is the erector spinae, the multifidus, the iliocostalis, longissimus. So these are all the erector spinae muscle group, which is going to help in mobility of the spine. So here is the coronal view. We will not much emphasize unless until there is a scoliosis or any other vertebral fractures or any other organ pathology. We don't see much of the coronal view, but still I can show you. Here is the lumbar vertebra. Here is the sacrum, L5, L4, L3, L2, L1. Here is the kidney here, and here is the iliac crest, the tip of the iliac crest. And what you see here is the sacroiliac joint. In ankylosing spondylitis, there will be some edema and irregularities you see in the SA joint. Otherwise, in general population, SA joint pathology is so uncommon. You don't see much of the problem over here. If you see 100 patients of low back pain, maybe one or two will be having problem coming from the SA joint, but majority of the pain would be coming from the intervertebral joint, where there will be a disc pathology or an adjoining facet joint pathology. All right. So you could see here the disc is healthy. The upper three discs are healthy, whereas L4, L5, and L5S1 disc is unhealthy and it's losing its color here. There should be always a concavity in the posterior aspect of the disc, or otherwise I used to call it as a heart-shaped disc in the lumbar spine, which gives a good space for the spinal canal diameter. In some cases, like in this case, you see suddenly the heart-shaped disc has become like a oval shape. So that means the canal diameter is going to get reduced as the disc is bulging. So this phenomena is called as diffuse disc bulging. That means the disc, which is normal, is in this level. As the level goes down, the disc is becoming bulgier and broader in the entire circumference. So if the disc is getting bulged in the entire circumference, we call it as a diffuse disc bulge. And such diffuse disc bulge has the capacity to compress the spinal canal. It also can cause reduction of the lateral foramen over here and over here. So let me compare both axial and the sagittal view together. So what you are seeing is the corresponding images of the single lumbar segment. So here the yellow color line represents where the cut is made, and that cut is corresponding to this image. So this is L4, L5 intervertebral cut, which is shown here, L4, L5 disc level. And here is the nerves which are clustered in the spinal canal. This is the exiting nerve root. This is the exiting nerve root. So in L4 and L5 level, the L4 nerve will be exiting and the L5 nerve will be traversing. What you see is the annular tear, which is appearing pretty white over here. The nucleus pulposus will try to find its way to come out of it. Remember, majority of the disc bulges would not have any pain. In fact, almost 80 to 90% of the disc bulges will not produce any pain. So that means our human body is so tolerant that it does not really complain even if there's a disc bulge. But in some unlucky people, the same disc bulge will produce symptoms. So in such cases, we call it as a symptomatic disc bulges. As a doctor, we don't deal with asymptomatic disc bulges. We don't even care about it. Most people will not even do an MRI to know that they have a disc bulge or not. But we are bothered about the people who are having symptomatic disc bulges like this. So this patient is definitely is having the pain because of the disc bulge. As you go the level down, you could see there is significant annular tear and diffuse disc bulge in L5S1 level. So this patient is having early morning stiffness, acute kyphotic deformity, SLR test is positive. He was not able to turn in the bed, difficulty to get up from the bed, coughing and sneezing is producing pain, severe spasm around the muscle. So these are all the clinical clusters that will tell that the pain is coming from the disc. So in such cases, we need to treat the underlying disc only. Once there is a degeneration, there is no regeneration in the disc. Once it becomes dark, it is always dark. It will never become white. So once the cartilage is degenerated, it is degenerated. Intervertebral disc is a form of cartilage, like how the meniscus is in the knee joint, same way the disc is in the spine. So both are falling under the category of fibrocartilage, and this fibrocartilage, once it is degenerated, it will not going to take the original shape. It's not going to become normal. How it was 10 years back, it will never become like that. But as a doctor, you can advise the patient to preserve the cartilage and to avoid further damage so that he can remain asymptomatic at least. If not, as the condition progresses, this disc bulge can one day become, I'm just saying can, not necessarily always, it can become one day a massive herniation, and that may require a surgical intervention because such massive herniations could cause bowel bladder disturbances or even muscle paralysis and so on. So when we see people who are having cardiac lesion and they come to us at the end stage, think in our back of the mind, only if these patients were cautious in the young age, or probably when the first pain came, they could have addressed it correctly. They would have reduced the load to the disc, thereby it would not have led to this catastrophic cardiac status. So that's why we need to see every patient as an individual patient. Every patient should be given a tailor-made exercise, loading and unloading patterns, and then education, ergonomics, and so on. So to summarize this patient, so this patient was diagnosed as two-level disc bulge, L4, L5, and L5S1. Posterior disc bulge, it's not yet compressing the exiting nerve root or traversing nerve root. That's why the patient is yet to have radicular symptoms. He's not having any pain in the legs, but the pain is largely in the lower back. So at this point of time, we asked him to restrict any weightlifting activities or forward bending activities. The current inflammation should subside. We have given him certain form of decompression exercise and some spinal correction exercises, do's and don'ts, and lot of education about how to prevent the next episode, how to remain painless in the entire life without getting one more episode. That involves a lot of science of knowing the biomechanics, the pathomechanics, the pathophysiology, neuropathophysiology of low back pain.